So, hi everybody, and today we are going to discuss the QRS, and in the QRS, we'll do the QRS, the causes of narrow QRS, and their EKG features. So, the narrow QRS may be divided into two types: physiological and pathological QRS, two types. So, before I tell you the causes of these narrow QRS, we'll differentiate between the narrow QRS and the wide QRS. Narrow QRS is supraventricular in origin, whereas wide QRS is ventricular in origin. And in narrow QRS, the block is proximal to the bundle of His, and in wide QRS, the block is distal to the bundle of His. And the treatment for the narrow QRS is adenosine mainly, and for wide QRS, the treatment is IV procainamide and amiodarone. Now, the causes of the narrow QRS are physiological and pathological. Of these two causes, pathological is divided into regular rhythm and an irregular rhythm, narrow QRS. The physiological narrow QRS may be due to bradycardia, tachycardia. It occurs in exercise and in children also. And pathological narrow QRS is divided into regular and irregular rhythm. So we'll discuss in this the pathological bradycardia and tachycardia. So we differentiate between the physiological and pathological bradycardia, and then the other causes of the regular narrow QRS are the first degree block. See, the first degree block causes the regular rhythm QRS narrow, whereas the second and third degree block cause irregular rhythm narrow QRS. Then we have the nodal or the junctional rhythm and AVNRT in the causes of regular rhythm narrow QRS, AVNRT, atrioventricular nodal reentrant tachycardia, then atrial flutter, cardiac tamponade, and acute lung conditions which have narrow QRS on the EKG. Then the irregular rhythm narrow QRS, we have sinus arrhythmia, premature atrial contraction, multifocal atrial tachycardia, second and third degree heart block. So, first degree block was in the regular rhythm narrow QRS, where second and third degree are they cause the irregular narrow QRS. Then we have atrial fibrillation in the irregular one. It is the most common cause of irregular rhythm. And then finally, atrial flutter with aberrancy and block. So, before we proceed on to discuss this, let's discuss the some basics. QRS duration normally is 0.12 seconds, and it corresponds to the phase zero of the action potential. And in the phase zero, there is rapid sodium entry into the cell. So that is QRS or depolarization, which is 0.12 seconds. Whereas ST segment is the repolarization, and that is about 0.35 seconds. So depolarization plus repolarization is QT. Both QRS plus ST is QT. So these are the causes of these here, and in ST there is calcium entry into the cell. So in QRS sodium entry, and in ST phase 2 is the calcium entry. Whereas in phase 1, 2, and 3 there is the potassium exits out of the cell, and then there is phase 4 or resting membrane potential. In hyperkalemia, this QRS is reduced in duration and in amplitude. So because potassium is related to the repolarization, so increased potassium also flecainide, they cause decrease in QRS duration and amplitude. So this is the phase zero of the action potential here, and here is the see potassium go inside potassium influx, and then in phase 1, 2, 3 there is potassium efflux, and also in phase 2 we have calcium influx. So this is the basics about it. And then ST segment, I told you the QT is QRS plus ST, and that is 0.12 plus 3, 0.32 ST segment duration. That makes QT interval 0.45 seconds. The causes of the QT may be prolonged. It is prolonged in it's prolonged in long QT syndrome and in torsady pontus. The causes of the QT prolongation, let me discuss it briefly here. It's caused by 5 A's: antiarrhythmics, that includes amiodarone. Amiodarone also used in uh, ventricular tachycardia and fibrillation, but not when its QT interval is prolonged. And amongst the antibiotics, macrolide groups and fluoroquinolone, antifungal, antipsychotics, haloperidol and thioridazine, and risperidone also cause long QT. And amongst the anti-ulcers, omeprazole, that is the most common cause of long QT syndrome caused by the drug. Omeprazole is a proton pump inhibitor and an anti-ulcer. And diuretics may also cause an electrolyte deficiency, hypokalemia, hypomagnesemia, and hypocalcemia also cause long QT syndrome. So this is what we did. We did the long QRS, narrow QRS, and wide QRS. The narrow is supraventricular in origin and wide in ventricular in origin. So we discuss now, we start doing the narrow QRS. The first is the physiological bradycardia and tachycardia, which is where there is narrow QRS with slow rate in bradycardia, less than 60 beats a minute, and the rhythm is regular, and the QRS may be contracted, and it occurs in athletes and during sleep, and it may also occur in diving seals where the heart rate may be as low as 12 beats a minute. And the treatment for the physiological bradycardia is atropine, isoproterenol, or theophylline. Whereas physiological tachycardia, see here, this one on the right, physiological tachycardia, sinus tachycardia, the rate is more than 100, rhythm is regular, and QRS is narrow here. And this occurs in this physiological tachycardia that occurs in fever. The mnemonics is FACE, FACE, F for fever, A for anxiety, C for children, and E for exercise. So these are the causes of the physiological tachycardia. Then we go to the next topic here. Let's see. The irregular rhythm, narrow QRS causes. So we also have bradycardia and tachycardia first here. So let's discuss that. And the other causes, the regular narrow QRS are first degree heart block, nodal or the junctional rhythm, AVNRT, atrioventricular nodal reentrant tachycardia, atrial flutter, cardiac tamponade, and acute lung conditions. Now, the first is the pathological bradycardia. Give me a second. Let me see. Okay, let's do the pathological bradycardia. We did the physiological bradycardia, which where the rate was slow and the rhythm was regular and was due to that occur in athlete and during sleeps. Well, this pathological bradycardia is divided into two: cardiac causes of the pathological bradycardia and non-cardiac causes. The cardiac causes mnemonics is MV, myocardial infarction, especially inferior wall MI may cause pathological bradycardia, although MI causes stress and tachycardia, but inferior MI is the one that causes bradycardia. And second is vagal stimulation, MV. And then amongst the non cardiac causes, the mnemonics is HIS, his. H for hypothyroidism, that causes bradycardia. I for increased intracranial pressure, and S for seizure. So these are the non cardiac causes of the pathological bradycardia. So cardiac causes are myocardial infarction, inferior MI, and vagal stimulation, and the non-cardiac causes are hypothyroidism, increased intracranial pressure, and seizures. Now, in the pathological tachycardia, so this was the physiological, and it was pathological bradycardia, now pathological tachycardia. Pathological tachycardia also divided into two same cardiac and related causes and non-cardiac causes. The cardiac causes for the pathological tachycardia are mnemonics is MAH2, M for myocardial infarction. See here, myocardial infarction that usually causes tachycardia, but inferior MI causes may cause bradycardia. So this is the difference. And then M for myocardial infarction, A for anemia, H for hypotension, and H for 2H, one H for hypotension, another one for hypoxia. Whereas non-cardiac causes mnemonics S2D2H, S2 sepsis, shock, that was called tachycardia. D for dehydration and drug withdrawal. Any drug that causes bradycardia, if it's removed suddenly, it will cause tachycardia. And H for hyperthyroidism. So hyperthyroidism causes tachycardia and hypothyroidism causes bradycardia. So these are the conditions that cause bradycardia and tachycardia. So we discussed pathological and physiological bradycardia and tachycardia, both with their causes. Then we have the first degree heart block. On the right, you see, this is the first degree heart block, and there is prolonged PR interval. So there is prolonged PR interval in the first degree heart block. The components of the PQRST, all of them are present. QRS is contracted, but only thing is prolonged PRI, PR interval, that is more than 20 milliseconds or zero point 0.2 seconds. So this is the prolonged PRI, is the first degree heart block, and the treatment for this first degree heart block is atropine, but this is worsened by carotid massage. So first degree heart block treatment is atropine, worsened by carotid massage. There is prolonged PR interval, contracted QRS, rhythm rate is normal, rhythm is regular. See here, this prolonged PR interval here, here you see, and the treatment is atropine, and this occurs in right-sided coronary artery disease, usually in coronary artery disease, but mainly in right-sided coronary artery disease that may cause first degree. Right-side coronary artery disease may also cause second degree block. Then the next in this list of, let's see, list of this regular rhythm narrow QRS is nodal or the junctional rhythm. The nodal or junctional rhythm. See on the right side, the upper EKG shows sinus rhythm. Normally, this is the sinus rhythm. All the components are present. But in the lower one is the nodal or the junctional rhythm. In this, the P is absent here. See, QRST, the other components are present, but P is absent. Rate is slow, 40 to 60 beats a minute. Why? Because the nodal or junctional rhythm originates in the ventricle, and the ventricle has the capacity to beat at a rate of 40 to 60 beats a minute. Rhythm is regular, rate is slow, QRS is contracted. So this is nodal or the junctional rhythm. Then we have AVNRT. Let's see. AVNRT, atrioventricular nodal reentrant tachycardia. There is a re-entry causing tachycardia. Where does the re-entry occur? At the AV node. Here, if you see this picture, so this is the impulse coming from atria into the ventricle, and it goes around the AV node, divide into two and around the AV node, and then unites here to move into the ventricle through the bundle of hairs. But if there is a block in one of them, then the other one that goes around the AV node again and enters back into the atria, causing reentrant tachycardia. So it's atrioventricular nodal reentrant tachycardia. So the rate, see here, and it comes on itself and it stops suddenly. So here, this is the EKG here. This is the normal rhythm. So it starts and it stops suddenly. Then it starts here. This one, regular rhythm, atrioventricular nodal reentrant tachycardia. All the components of the complex are present, PQRST, but only thing is the rate is fast. And it will, here it continues, and then it ends here suddenly, and it stops itself and become a regular rhythm. So it starts and it stops itself. And this is caused by increased sympathetic activity, exercise, emotional stress, alcohol, tea, or coffee. So, this is what is the nodal reentrant tachycardia due to re-entry of the impulse back into the atria going around the atrioventricular node. And the most common cause of this AVNRT is the paroxysmal supraventricular tachycardia that comes on itself and goes itself. Then we have the treatment, sorry. And the treatment for the nodal reentrant tachycardia is the mnemonics is divided into two, non-invasive and invasive. And the mnemonics is A, B, C, D, E. D is blue and here at lowercase, so it's not included in the mnemonic. So A for adenosine, B for beta blocker, C for calcium channel blocker, and E for electrocardioversions. So these are the non-invasive or the drug causes of the AVNRT treatment. And the invasive causes is catheter ablation that removes the nodal reentrant tachycardia, and especially the right fasciculus ablation causes is 90%, 95% successful. The other treatment also may be carotid sinus massage. See here, for the nodal reentrant tachycardia, carotid sinus may be done, but for the first degree heart block, carotid sinus is not done. In fact, that increases the block. Then the next cause of this here is atrial flutter for the narrow QRS regular rhythm. So this is here atrial flutter, which has the sawtooth. P wave is sawtooth. There is the 2 is to 1, 3 is to 1, or 4 is to 1 block. And the rate is 240 to 360 beats a minute here. And not all the impulses pass through the AV node, but it's still the ventricular rate is 80 to 120 beats a minute and QRS is narrow. So in atrial flutter, we have this sawtooth P wave, narrow contracted QRS. A rhythm is P wave is 240 to 360 beats a minute, and the QRS is ventricular rate is 80 to 120. So there may be a tachycardia, and the block is this 2 to 1, 3 is to 1, and 4 is to 1, and the QRS is narrow in atrial flutter with a regular one, narrow QRS. Then we have this cardiac tamponade. Here, this occurs in pericardial effusion and pericarditis mainly, where there are the pressure in all the four chambers is same or equal, and the cardiac sounds are muffled. Here we have this low voltage narrow QRS alternatively. This is known as electrical alternance, and the other causes that may cause the electrical alternance are COPD, and the mnemonics is PCOM, P for pericardial effusion, pericarditis, and C for this COPD, O for obesity, and M for myxedema. So obesity, myxedema, and COPD may also cause cardiac tamponade, which has alternate low voltage QRS complex, is known as electrical alternance. You see here, electrical alternance, alternate low voltage EKG here, this one. Okay, and the next cause is pulmonary conditions that causes the irregular rhythm narrow QRS. So these are acute pulmonary condition, tension pneumothorax, and pulmonary embolism. And EKG feature in the acute pulmonary conditions are that of S1Q3T3, S in long lead 1 here, S1 Q in long lead 3, and T inverted in the long lead 3. So it's S1 Q3 T3 pattern in the acute pulmonary conditions, and that is tension pneumothorax and pulmonary embolism. Then after that we move on to the so we've done the regular causes, and then we go to the irregular rhythm narrow QRS. So these are the causes of irregular rhythm narrow QRS: sinus arrhythmia, premature atrial contraction, multifocal atrial tachycardia, second and third degree heart block, atrial fibrillation, the most common cause, and atrial flutter with aberrancy. So give me a minute, let me check. So here we do this sinus arrhythmia, the first cause of irregular rhythm. Here the rate is not increased, the rate is 60 to 100. But you see the narrow QRS, P is present, but there is a rhythm disturbances, an extra beat arising. Here, this is the normal gap between the normal rhythm QRS, but this one here comes before the time. So this is the beat rate is 60 to 100 beats a minute, regular, irregular one with a regular rhythm and with a regular rate or normal rate, but the rhythm is irregular. P wave before each present, and a QRS is less than 0.12 second. And then why is not coming over here on this? Huh? Okay, let's see. This page is not visible here. Okay, that's not. Oh, I see. I was on the wrong page. Then we have premature atrial contraction. There are premature beats. They arise from ectopic atrial pacemaker. An abnormal P wave occurs earlier than expected, and there is a gap. There is a gap here in the premature atrial contraction. See here, the earlier we discussed premature sinus arrhythmia where there was no gap. But this one here on the left, we have premature atrial contraction. So there is a gap after that. And it may be due to alcohol consumption, smoking, or stimulants use. Premature atrial contraction arising from ectopic atrial pacemaker that cause irregular rhythm. And the next cause of the irregular rhythm is multifocal atrial tachycardia. Here, irregular rhythm and then multifocal atrial tachycardia, irregular rhythm. So here we have multiple foci in the atria, multifocal atrial tachycardia. Rapid that causes rapid and irregular atrial rhythm. The heart rate is more than 100. Rhythm is irregularly irregular. See here, let me see. And the characteristic EKG feature of multifocal atrial tachycardia is the variability in the morphology of the P wave here. You see this in the same lead, yes, for more than 3 seconds. Here the P wave is different configuration. The morphology of the P is different in the same lead. That is the characteristic EKG feature of multifocal atrial tachycardia. So we've done here this sinus arrhythmia with a focus in the atria, focus there, and then we have the premature atrial contraction in the irregular rhythm, multiple foci of rhythm, multiple foci in the atria, ectopic atrial pacemakers. There is a gap. This is the abnormal one with a gap. And then we have multifocal atrial tachycardia with variable morphology of the P wave in the same lead. And this may be due to COPD, infection, or cardiac decompensation. Then the next cause of this irregular rhythm narrow QRS is second degree and the third degree heart block. So the second degree heart block, this also occur in coronary artery disease, especially right coronary artery disease may cause first and second degree block. So there are two types of second degree heart block. Morbid's type 1 and Morbid's type 2. So what's the difference between the Morbid's type 1 and Morbid's type 2? In Morbid's type 1, there is progressively increasing PR interval. See here, the boxes for the PR interval as shown here. Let me see down here, this one. There is progressively increasing PR interval in Morbid's type 1, followed by a drop beat here. Progressively increasing PR interval, followed by a drop beat. This is second degree heart block, progressively increasing PR interval here on the left, and this one is a drop beat. Whereas in the Mobitz type 2, there is fixed PR interval. Compare these boxes. They are fixed, same in position. Whereas here, this box was increasing in the Mobitz type 1. So in Mobitz type 2, there is fixed in PR interval followed by a drop beat also. So both Mobitz type 1 and Mobitz type 2 second degree heart block have a drop beat, but in Mobitz type 1, there is progressively increasing PR interval followed by a drop beat, whereas in Mobitz type 2, there is a fixed PR interval followed by a drop beat. So this second degree heart block may also cause a wide complex QRS, and second degree heart block, if the block is proximal to the bundle of hairs, then the QRS will be narrow. Whereas if the block is distal, then QRS will be wide. So this is the second degree heart block that occur in inferior MI and cause a second degree and higher proximal block. Inferior MI, right? Block and bradycardia, inferior MI that causes second degree block. And the treatment of the block is atropine, isoproterenol, and exercise. So the QRS is contracted in these, right? The rhythm is irregular and the P is present with a drop beat in between. With a PR interval increase in morbid type 1 and fixed PR interval followed by a drop beat in the morbid type 2. Then third degree heart block also causes irregular rhythm Atria and ventricle beat their own. P is independent of QRS. Atria independent of ventricle. And this occurs in septal MI, third degree heart block, and occurring in septal MI, but may also occur the other causes, and the treatment is permanent pacemaker. Third degree of heart block may also cause a narrow QRS or a wide QRS. Narrow QRS if the block is proximal to the bundle of his, and wide QRS if the block is distal to the bundle of his. And the causes of this are DMVE, mnemonics D for drugs, M for MI, V for vagal stimulation, and E for electrolyte imbalance. And the clinical features are 5 Ds: decreased blood pressure, dyspnea, dizziness, and disorientation mentally. So these are the clinical features of the third degree heart block. Then we move on to the next, and that is atrial fibrillation, the most common cause of irregular rhythm, right? And atrial fibrillation, the P wave is absent or fibrillary P wave, and it is the fastest heart rate that occur in atrial fibrillation. Any fibrillation, atrial or ventricular, has the fastest heart rate. In atrial fibrillation, this has the P wave here, fibrillary P wave, but in ventricular fibrillation, there is QRS, fibrillary QRS. So here the multiple foci discharging asynchronously, and that produces fibrillary waves, and it's unable to push the blood into the ventricle because of individual muscle fiber contraction. So their neck vein got engorged, and there is AV dissociation. Heart sound S1 is split or variable and loud, and in this, the, not all the impulses pass through the AV node into the ventricle, but still the ventricular rate is high in atrial fibrillation, is more than 120. So QRS is contracted in atrial fibrillation, and P rate is 360 to 600. QRS is contracted and narrow. So its complication of atrial fibrillation is ventricular tachycardia. Also in atrial fibrillation occurs mural thrombus formation that may dislodge and damage any other organ, especially may cause a stroke. So the treatment for the mural thrombus in atrial fibrillation is warfarin. And T waves are also inverted in the atrial fibrillation because of ischemia. So the treatment of the atrial fibrillation is drugs or non-drugs. Drug that may be used in atrial fibrillation: A, B, C, D, W. A is lowercase blue, so not included. B for beta blockers, C for calcium blockers, D for digoxin, and W for warfarin to prevent mural thrombus and stroke. And in the non-drug causes, we have cardioversion and pacemaker, PC. Then we have the atrial flutter with aberrancy also causing irregular rhythm. Normally it causes regular rhythm, I just discussed earlier. But when there is a atrial flutter with aberrancy, it may cause irregular rhythm. See here, this atrial flutter sawtooth 2:1, 3:1, 4:1 block, and the rhythm is irregular here because of the aberrancy. So it causes also dizziness and hemodynamic instability. And the treatment for the atrial flutter is synchronized cardioversion with defibrillator. So here we have this done, the causes of the narrow QRS with EKG, and the next we will do in the next session, when maybe next week, wide causes of wide QRS, and we'll discuss all the EKG features of the wide QRS. So here we have done all this narrow QRS today causes. So maybe I can repeat if possible. Let's see here, narrow QRS here. physiological and pathological causes, bradycardia, tachycardia, physiological causes, and in the regular rhythm narrow QRS, we have bradycardia, tachycardia, first degree block. We discussed all of them. Nodal or the junctional rhythm, AV and R3, atrioventricular nodal reentrant tachycardia, and atrial flutter, cardiac tamponade in acute lung condition that cause regular narrow complex QRS complexes. Whereas we discussed the other causes of narrow QRS with irregular rhythm, sinus arrhythmia, premature atrial contraction, multifocal atrial tachycardia, second and third degree block, atrial flutter, atrial fibrillation, and atrial flutter with aberrancy. So this is the end of the today's discussion, and we have been, let's see, we did all these EKGs for, let me begin from the beginning, go back around here. So these were the causes of the narrow QRS, bradycardia, physiological bradycardia and tachycardia, and then pathological bradycardia and tachycardia. And then we had the first degree block with EKG. Then we had the nodal or the junctional rhythm. See here, nodal and the junctional rhythm. Then we did the AVNRT with PSVT, paroxysmal supraventricular tachycardia here with this EKG for the AVNRT and paroxysmal supraventricular tachycardia. Then we did the treatment of that as ABCDE, the mnemonics, and then we did the cardiac tamponade, in which we had this alternative low voltage EKGs or QRS complexes. And then see here, alternate low voltage QRS complexes in the EKG, then pulmonary condition causing S1, Q3, and T3. So these were the causes of these, and then we did these causes were the irregular rhythm, and then we did the irregular rhythm. In that we did this sinus arrhythmia, then we had this EKG of the premature atrial contractions, and then we had the premature atrial contraction. Oh, and this one was, yeah, this one was premature atrial sinus arrhythmia, premature atrial contraction, and then we had this multifocal atrial tachycardia, multiple foci discharging in the atria. And then finally, we had this second and third degree heart blocks, Mobitz type 1 and Mobitz type 2 with the EKGs, and then atrial. Let's see, what was the next? That was third degree heart block, and then we had this third degree atrial fibrillation, and finally atrial flutter. So this is the end of the day at almost 40 minutes. So see you in the next session, maybe in the next week. That's it.